During the talk that I'm presenting, I will be looking at novel mechanisms leading to low platelet counts in immune thrombocytopenia, specifically addressing the role of glycans or the sugar coating of platelets, both in platelet survival and also in platelet destruction in ITP. We have experienced significant advances in the field of ITP with the introduction of novel therapies, and there are many more therapies coming to treat these patients. But still, there are about 20% of patients that are multi-refractory that do not respond to any of these treatments. And in that sense, our study provides novel data about potential therapeutic treatments for these multi-refractory ITP patients. Currently, and unfortunately, we don't have enough data to replace corticosteroids as the first-line therapy for ITP patients. When a patient, which is most of them, fails first-line treatment because they lose the response or they do not respond in the first hand, then we move on to the second-line therapy. Right now, in most cases, we will discuss with the patient, but usually TPO receptor agonist is the preferred second-line therapy. In some patients, they will go for a splenectomy because they want to get rid of any ITP treatment to increase platelet counts. And also immunosuppressants can be an option for this treatment. But the important thing is try to avoid giving them further corticosteroids once they have failed the first-line therapy with this kind of drugs. I think it is important that in the future we work to try to classify ITP as different disorders. It is clear that ITP is a very heterogeneous disorder, and if we try to dissect the specific pathogenic mechanisms leading to the low platelet counts, we can advance in the treatment of these patients. Right now, it is not possible to know in an individual patient the prevailing mechanism leading to low platelet counts, so that probably we will have to look at targeting different pathways and not focusing just in one treatment and then second treatment, third treatment, stepwise, but a combination of treatment, because probably considering that ITP is a syndrome, just targeting one player will not let us win the game. We have to target different players so that maybe we can increase the platelet responses and avoid the different side effects of different treatments when they are applied one after another as single therapies. But a combination therapy would probably be most appropriate in many patients.